folks. This is Jennifer from the Family Health Outcomes Project. I think we've still got a few more people that are joining the webinar, but we've got a very packed webinar planned for you all, so I want to get us started very soon. So today we're going to have three special presenters from the Lucille Packard Foundation presenting on California children with special health care needs and their families, current issues and challenges facing our most vulnerable populations. The presenters include Dr. Ed Shore, who as Senior Vice President of Programs and Partnerships at Lucille Packard Foundation, directs the programmatic and grant-making activities, with the latter focusing on healthcare systems improvement for children with chronic health conditions. Prior to this position, he was the Vice President at the Commonwealth Fund, where he led efforts related to child health policy and practice and state health care reform. He was the Medical Director and Policy Director for the Iowa Department of Public Health, and earlier in his career, Ed was Medical Director of the Chesapeake Health Plan of Baltimore, Chief of the Division of General Pediatrics at the University of New Mexico, responsible for grant-making programs on medical education, medical ethics, and improving functional outcomes and well-being with the Henry J. Kaiser Family Foundation, and Director of the Functional Outcomes Program at the New England Medical Center. And he's done a lot more before that, but that's going to be all we're going to say for Ed right now. We also have presenting Henry, and prior to joining the foundation, Holly served as the Project Director and Research Associate at the Johns Hopkins School of Public Health, where she managed several international and domestic research studies focusing on child and adolescent health issues, including obesity prevention, media use and awareness, HIV prevention, and tobacco marketing. She has studied the effects of health-related programming developed by Sesame Street Workshop and MTV on children's knowledge, attitudes, and behaviors. She's also served as Nutrition Policy Project Associate at the Center for Science in the Public Interest in Washington, D.C., where her work included advocacy for improvement in school meal policy. And then finally, we have Allison Gray, who's a program officer at Lucille Packard Foundation. Allison managed Family Voices of California Project Leadership, a statewide parent advocacy training program for caregivers of children with special health care needs. She serves as the family leader of the California Association of Maternal Child Programs, AMCHIP, and is a member of the AMCHIP Family and Youth Leadership Committee. She is also the advisory committee for the funders group of parents organizing family engagement and leadership development. She also represents Family Voices of California on the Western States Regional Genetics Network. Parent of a child with special health care needs, Allison is dedicated to ensuring that family perspective is valued at all levels of the healthcare system. So without further ado, we're going to turn it over to our very esteemed presenters. We are going to be pausing for questions after each one of the three presentations that we're going to be having today. You have the option of chatting a question to us. We will try to unmute people as well so people ask questions orally, but if we get excessive background noise, we will have to just do questions via the chat function. So, Dr. Shore, welcome you.
Jennifer, and good afternoon to everyone. I'm pleased to be here speaking on behalf of our foundation. Colleagues and I have a lot of information to share with you. I want to let you know that our slides will be available afterwards. We're going to go through them fairly quickly, but some of the content might be useful for you in your own work to spark some discussions about some of the issues. Also, our website at the Lucille Packard Foundation for Children's Health has a lot of content related to what we're going to be covering, as well as some other topics that we won't have time for today. And at the conclusion of our work this afternoon, we will be providing a resource list of specific things that people might find interesting. So here are my three colleagues. We're a small foundation. We are the three program officers for the foundation. Our larger mission is for us to improve the systems upon which children with special health care needs and their families depend. We take a systemic view as opposed to a clinical view on the topic. We've divided our grant making and other activities into these three categories. Let me begin with the first one, which is where I will be discussing mostly, and that's working on system standards and quality. I'll come back to that, but we feel as though the system of care needs some standards that people can be held accountable to, and measurement can be done around. Second category was really in response to parents saying that the thing that they needed most was help with care coordination. And so we've devoted one of our core activities to trying to improve care coordination for these children and families. Another thing we hear from families, first of all, is that they want to be part of the process. They want to fix the system. They want to be heard. And so we are devoting a lot of efforts under Allison Gray's leadership to figuring out how to best engage families, and Allison will be talking about that. In addition, we're interested in making sure that families have the support they need to carry out their own roles as caregivers and to participate in policy and programmatic work. These are the objectives for today. We'd like to provide you with an overview of some of the topics that are our priorities. We hope that it'll suggest some issues to you that can be addressed by your work and public agencies, and can be a resource to help guide new programs and policies. We bring a toolkit of a few things. We obviously do grant making. We solicit grants proposals ourselves, and we accept unsolicited proposals. We're engaged in advocacy directly and through advocacy organizations. We do a lot of communication work. We have a biweekly newsletter that I hope all of you have signed up for. We produce issue briefs and policy briefs. We do convenings, and we have webinars. And we engage with communities in California to try to improve services locally. You can learn more about our foundation's work at our website, the address of which is here. Takeoff point for some of our work, and this is older data, but I don't have any evidence that it's changed substantially since it was collected in 2009, that shows the quality of health care for children with special health care needs in California is in need of some improvement. I believe, although we have very little data, that the quality of medical care, particularly specialty care as given by specialists and hospitals in California, is of high quality. We have some issues with not being able to measure that quality well, but it's certainly, I think, good and equivalent to what you can get in other parts of the country as well. However, when you start looking at the systemic issues of the system on which children depend, you start finding issues with children obtaining preventive care, getting care coordination, having family-centered care, and so on. We rank at the bottom on a number of these issues in terms of national rankings, and not much above that in some other characteristics as well. So our focus is in our work on children with special health care needs. The slide contains the definition that is used by the Maternal and Child Health Bureau. It's a very encompassing definition. And in truth, beyond this one, there's no gold standard for what constitutes a special health care need or how you identify a population of children with special health care needs. The definition that you choose depends on the purpose for which you want that definition in order to identify children. Here's a way of categorizing children according to their health status. It's a tiered or stratified model. It's not based on diagnoses, which is the model that is used in the California Children's Services Program. It's a diagnosis-based categorization. This one looks at whether or not a child has chronic illnesses, episodic chronic illness like asthma that may come and go, or allergies, lung chronic illnesses, progressive chronic illnesses that are dependent on technology, and a small group of children also who have malignant disorders. What you can see from this graph is that it excludes children with no chronic condition and children whose chronic conditions are readily managed and are episodic. You're left with less than 3% of the population defined as children with special health care needs. The more severe they go in terms of their conditions, the more complex they are. There's a interest in the United States now in complex care. Most of that interest that we read about publicly is focused on adults, but there is quite an active movement now to identify children with medical complexity. Trying to define them is as tricky as defining children with special health care needs. But here is one definition, some characteristics that help us define who might be labeled a child with medical complexity. And we would want to label children according to this or the previous triangle that you saw, because we want to figure out who needs what services and make sure that services are given to the children who they do need. You can see for yourself the characteristics of complexity which makes children vulnerable. The importance of this population is evident by looking at the second box in this slide, which shows that these are a very small portion of children overall, but they account for a huge portion of healthcare costs, hospital admissions, Medicaid costs, and are disproportionately served by public health programs, particularly Medicaid and Title V. So we, in our work, focus to some extent on children with complexity. They are the canary in the coal mine for where the system is or is not working. And we believe that if we can develop a system that works for them, it'll work for other children with special needs, in fact, would work for all children. This is some data that Lee Sanders from Stanford has provided to us, just to tell you a little bit about the kids who are on the CCS program. CCS enrolls probably slightly less than half of the children with special health care needs in California. The children they do enroll are disproportionately Hispanic, disproportionately served by Medicaid, and high rate of complex conditions as well as simply chronic conditions that are not complex. One of the things that the complexity of these children is that they depend on or are interacting with a large number of other systems that interact with, or should ideally interact with, and ideally be integrated with, the healthcare delivery system. So there is a lot of comorbidity among children with special health care needs in the CCS program, particularly in terms of having developmental disabilities and mental health needs. Many of them are in special education, and many of them are foster children who are served by the child welfare system. We've thought a lot about over the years what would make a good system for these kids. If we're trying to improve the system, what would make a good system? And here are 5 characteristics that we sometimes refer to help us think through the direction that we're going and that we hope you're going in serving these kids. So they need a whole child, comprehensive, coordinated system of care. They need service plans that cross all those agencies with which they interact and information sharing across those agencies. The system has to have meaningful family engagement, and Allison is going to touch on that. We need equity of access to good quality services. We have some work going on now that points out some major disparities in access to services, particularly those from the regional centers. I won't talk about that today. And we need transparency in the quality and access of these services so that we know that the children are getting what they need. Here's a picture of how CCS is spending its dollars. By and large, most of the dollars are going to hospital care and outpatient pharmacy. Are significantly smaller. So if you're trying to save money in a system, obviously those are the two places that you want to focus on. Some data on children with medical complexity, just to highlight the difference between them and children those children who have medical complexity who are offered a high quality system versus those who are getting usual care. If you offer a high quality comprehensive system, their medical care costs annually are substantially less. Outpatient costs actually go up, but you save on hospitalization. ED visits for some reason go up, and that's still being explored. Hospital visits obviously are down. ICU admissions are down. IC days are going down, and serious illnesses are going down. So there is good argument for the work we're trying to do to improve systems of care for these children. Some things that generally are missing in our existing system of care. So if you're trying to figure out what you want to work on and how to improve services for children with special health care needs, here's a list you can work off of. I won't go through them all. Most of you could probably create this list yourself, but I think it's worth keeping in front of you as you do strategic planning for your agencies and programs. The California Children's Services Program, the CCS program, has initiated a whole child model where they're transitioning children from what's on the left, their traditional program, which is a mix of both traditional fee-for-service services for CCS eligibility conditions, plus Medicaid managed care for non-CCS conditions. They're transitioning to the whole child model, where the children will get both kinds of services from a Medicaid managed care organization. Only about, actually less than a quarter of the children in the CCS program are being moved into the whole child model. 3/4 or more are going to remain in that traditional model. So although there's lots of interest in the whole child model and we can learn a lot from it, and the previous slide that I showed you said that we could save a lot of money and a lot of hospitalizations by doing comprehensive services, we don't have an answer for the children who are going to continue in the traditional program. Move into the managed care whole child model program has made parents very anxious, not just in California, but all over the country. If you look at the bottom of this slide, in the 1990s, most children with special health care needs were receiving their care through a fee-for-service model. At 2017, 37 states were mandated managed care enrollment for children with special health care needs. So this is a national movement. California is actually coming late to the party. But in all these cases, parents have been worried. They're worried that the managed care companies are going to manage costs and not care. They're afraid their children are going to lose benefits and have barriers to the care, that they're not going to have the access they've had previously to subspecialists, that continuity is going to suffer, the quality is going to suffer, and that care is going to be fragmented. And all the work that parents have done individually to create their own little private systems are going to be lost in this transaction. A feeling at the foundation is that care, if bad, will create bad outcomes, but if good, could actually address all these concerns that parents have and actually improve care and improve outcomes for children. So the first project I want to mention to you is one in which we've developed through a grant to the Association for Maternal and Child Health Programs and the National Academy for State Health Policy, have developed national system standards for children with special health care needs. This was a major undertaking, a national consensus process that had federal representatives, families, policy people, state Title V, Medicaid people, researchers, and health plans all contributing through a quite extensive process that actually led to the national standards. They came out in about 1915 was the first release of those standards, and they have subsequently been revised. I want to point out to you the 10 categories, the domains of system capacity, if you will, that this process identified as being important to address if you're going to have a high-quality system of care for children with special needs. This picture you're seeing is the cover of the version 2. Version 1 is there and is also much more detailed. It includes about 100 individual standards. It's available at the NASHB website and also at the AMCHIP website. Started using these. We know of at least 38 states that are using the standards in one way or another, whether that's the Medicaid programs or the Title V programs. One of the first steps they're doing is making sure they are identifying children with special needs as an identifiable population. That means they have to have a definition and ways of identifying the kids so they can target services to them. Also using it for giving the quality of services that are being provided by the systems of care, by these healthcare generally managed care systems. States are using the standards to guide their strategic planning activities. They're using the content to help develop contracts with managed care organizations. It's being used as a vehicle to create partnerships among all of the stakeholders concerned with the health care of these children. And it's being used by state governments and local health systems to think about how they can improve their own care systems. Second project that we've done that I wanted to highlight is a project that was triggered by the Center for Medicaid and Medicare's work on the triple aim. If you recall, the triple aim, if I can recall, is to improve the quality of health care, to improve, to control the costs of health care or get value, and to improve the health of populations. And that led us to wonder, what's the health of the population of children with special health care needs? So first we'd have to identify who we're talking about, but then we have to figure out how do we measure their health. And that becomes very difficult, as all of you, I believe, know, because the diversity of conditions that these children have is quite different than the pattern you see with adults, for whom about 5 chronic conditions capture most of the adult chronically ill population. For children, I saw a figure of about 7,000 different diagnoses that could put a child in this category. So how do we do generic health status measurement, health quality measurement, health measurement in general that doesn't require us looking at the care of individual clinical conditions? And work by some people at UCLA have come up with this list of categories in which we could measure and should measure child health outcomes as consequences of the services and systems they're getting. We have measures for some of these. We don't have measures for others, and there is no single instrument currently that really taps at all of these measures that can be used by a health plan. Now, most of these measures are in the National Survey of Children with Special Health Care Needs, although that's been changed over the last 2 years, and we may not have good data going forward. But that just gives you a big picture, national or to some extent state level data. If you want to know how your health plan or your county is doing in terms of serving these kids. We don't have a mechanism right now. But these are the ways that things we ought to be looking at if we want to know how are these children doing as a group, how effective is our system. The third project and final one I want to mention is a project we've been doing in Oregon. We were contacted by people in Oregon who wanted to figure out how community pediatric practices could better serve children with special health care needs, particularly children with medical complexity. Oregon is a fairly rural state. The need to serve these kids in some remote areas is fairly high, and they're trying to figure out how do you go about doing this. Their first step was to figure out who are the children with medical complexity. Their Medicaid department took an algorithm that was developed by researchers that could run against their Medicaid database, and that allowed them to pull out the children who met criteria for having medical complexity. Then they went one step further, and this is, I think, really exciting and cutting edge. They said, a lot of discussion now in the last year or two particularly about social determinants of health, about the fact that there are social and personal factors that interfere with people's ability to obtain health care and to benefit from health care. And so you see poor health outcomes that are really driven by social circumstances. And so they created another algorithm that they ran against their database to identify the children with social complexity. And when they combine them, they say if a child has medical complexity and social complexity, they describe that child as having health complexity. If you're, I guess everyone's got a computer screen, so this is probably readable. This is not a slide I would project. But these are the indicators that Oregon has been using, they're enhancing it, to identify social complexity, and they've identified it in terms of factors that are fairly central to the children and factors that are emanating from their family's circumstances. They're able to then identify the children for medical complexity, second for their social complexity, and finally what they've been able to do is to create this 3x3 table. So you have down the side 3 categories of medical complexity: high complexity, moderate complexity, and children with no chronic conditions. So, and the moderate are kids who have chronic illness but really don't qualify as complex. So we have complexity, chronic, and non-chronic. Across the top, they simply use the number of social complexity indicators they had, a possible number of 12. And you can see that they've divided it up into kids who have 3 or more indicators, 1 to 2, or no indicators. So the upper left-hand box tells you that they have 3% of the children in Oregon Medicaid who have both high medical complexity and high social complexity. What they're going to be able to do with this data is say to a health plan, here's your 3x3 table of the kids who are enrolled in your managed care program, so you know how you're going to have to plan for your service delivery. Ideally, they're going to be able to give this kind of a categorization to individual practices as well, so the practices will know, well, they have hardly anybody with social complexity, so they don't need a social worker, or they have huge numbers of kids with social complexity, and they're going to need to beef up their capacity to serve that population. So I think this is a real breakthrough in thinking about how we create systems and allow systems to be knowledgeable, so they're going to be able to better serve their populations by identifying who their high-need patients are. So I'll stop there. We'll take some questions if you have some, and move on to the next speaker.
So I have people muted at this point since there was a lot of background noise, but if people want to type in questions or if anybody wants to raise their hand, we can certainly unmute you. Questions for Ed at this point? Oh, I'm not hearing or seeing any questions. Adrienne, are you seeing any questions coming in?
One question just came in, and that is, can you give a few examples of chronic but not complex conditions?
And probably the best way to do that is to slide. Find kids with complexity. So these are children who have chronic and severe health conditions who are cared for by 2 or more pediatric specialists. They may be technology dependent. They generally have multiple body organs affected, and they have functional limitations, so they're not able to do all the things that a child their age would be willing to do. As I said, there are other ways of defining with medical complexity. It really depends on what you're trying to do with the definition. This is a definition that's used by one clinical service to identify who's eligible for their specialized clinic.
Other questions?
Not any hands raised. And was any other questions? So, like I can give the next presenter presenting rights.
I think next up we have Holly Henry then. And everybody saw Ed's slide, which will be in the slide deck. So if people do have follow-up questions for Ed that they think of later, you've got his email address and his contact info.
Thank you for the great overview, Ed, and for the wonderful questions. Now I'd like to talk about a specific area of interest for our foundation and children and youth with special healthcare needs and their families: care coordination. Likely, many of you have seen this image before. This is a care map. This particular care map, developed by Kristen Lind, is a quintessential example of the care that families are managing. After she drew this map detailing the health, developmental, school, info, advocacy, leadership, recreation and community, legal and financial, and support services required by her son G, Kristen was asked by experts in care coordination at Boston Children's Hospital to help design a workshop to teach other parents how to draw their own care maps and use them for advocacy. I share this care map to remind us of the myriad of services that families need for their children. What this map illustrates is that the family is at the center of all care coordination. You can see there are at least 73 individuals and service categories represented on this map. And each set of these services branches out like a spoke. So I'd like you to think about some terms that come to mind when you look at this map. Much of the research I'll talk to you about describes it as fragmented, siloed, complex, and confusing, and describes families needing to navigate the system. With the family at the center of this map, they must also serve to connect between points. For example, connecting their pediatrician to the specialty hospital or the occupational therapist in the school to their developmental disabilities therapy services. After looking at this, it's no surprise that care coordination has been defined as the set of activities that happens in between. By this, we mean activities that happen in between visits to the doctor, in between providers or hospital stays, in between insurers, or in between organizations and agencies. And as you know, being MCAH directors, these agencies and organizations often do not communicate with each other, and they do not know what services other organizations represented on this care map offer or pay for. To bridge the gap, the parents take up the slack. Families of children with special healthcare needs often find themselves going back and forth from one agency to another, trying to secure services and equipment that their children need. The result is that these children deal with challenges that affect their health and quality of life, and their already burdened caregivers must spend countless hours trying to coordinate their care. This is not just an issue for families, although families do bear the brunt of it. Back in 2012, we surveyed the readership of our network newsletter, which includes policy researchers, providers, families, and advocates, about the most pressing challenges in caring for children with special health care needs. And the top issue that came out from that survey was care coordination. So I think it's fair to say that care coordination is one of the greatest needs of children and youth with special health care needs in our state. This is a visual representation of what care coordination looks like. This family, while waiting for an appointment, the child's mother is working on paperwork. The father is helping the child with homework. Both of these parents work from home so that they can manage their child's care. And a grandmother picks up the other children in their family from school so that both parents can attend this appointment. All of this child's appointments are 30 to 60 minutes driving from his school, and he must also travel every few months outside of the state to participate in a research study. So now that you have a sense of the types of things parents are trying to coordinate, what is care coordination? Well, there are many definitions that encompass care coordination, but this list here shows some of the elements we see as vital. This comes from a definition by the country's expert on pediatric care coordination and one of our grantees, Rich Antonelli. His definition, which the American Academy of Pediatrics also uses, describes individualized pediatric care coordination as family-centered, that is designed to meet the needs of families and designed in a culturally competent and accessible way. Assessment-driven, that is that care coordination services should be based on a formal assessment or assessments of the needs of a child and their family. A team-based interdisciplinary activity where all relevant members of the care team are involved, and that it should be guided by an individualized care plan, which is designed to meet the ongoing needs of the children and youth while supporting and enhancing the caregiving capabilities of their families. And I'll share some resources later on in the presentation that you might use in promoting this type of activity within your counties. There are benefits to care coordination at different levels, from individual to organizational. Many of these benefits have been documented, often looking at coordinating care for adults with complex medical and social needs, but increasingly with pediatric populations. As you can imagine, documenting the outcomes of care coordination actually requires documenting outcomes that were prevented by effective care coordination. So for example, prevention of visits to an emergency room or prevention of a readmission to a hospital. In terms of the Title V needs assessment, I want to make it clear that care coordination is a documented need for children and youth with special health care needs and their families. And you also have a ready audience of different stakeholders that stand to gain from improving this system of services and better coordinating care in your communities, from patients and families to clinicians and healthcare organizations. Although the benefits are quite clear, there are significant barriers to care coordination. Researchers from the Catalyst Center, which is part of Boston University's Center for Innovation in Social Work and Health, described in a project funded by our foundation that there is a care coordination conundrum. Everyone agrees it is a vital and necessary service, but there is disagreement about who should provide it, who should get it, how much should be had, and who should pay for it. Other barriers from a provider perspective are time and money. Coordinating care for children and youth with special health care needs is not a quick process. A normal pediatric appointment may take 15 minutes, but developing a care plan, which is the basis for care coordination, may take several hours, and there is no reimbursement mechanism for this time. So another barrier is that although parents are at the hub of the care map, as you saw before, there is no designated leader when care is being coordinated across systems. Families often lament who coordinates the coordinators, alluding to the fact that each set of services may assign a coordinator, but those coordinators only work within their own service line. As a result of these barriers, almost half of parents of children with special health care needs in California report that they do not receive effective care coordination. This is actually a few points higher than what is reported nationally, and this is an area that is ripe for improvement through the 5-year planning process. The source of this data is the 2009-2010 National Survey of Children with Special Health Care Needs. This next image illustrates that there are care coordination responsibilities across our healthcare system, from the federal government down to individual caregivers. And you can think about where you sit within this. For most of you, you sit within county government and regional programs. And sitting in the middle means connection to all the other parts. Some activities that county government and programs could take part in include creating data sharing agreements, standardizing care coordination processes, establishing financial responsibility agreements among public programs, and sharing eligibility criteria. As I was researching in advance of this presentation, I read over the strategy statement of the MCAH program online. It was very similar to our approach, which I list here on this slide. The MCAH strategy documents state that there should be strong partnerships built at the local, state, and national levels to coordinate systems of care and improve access to care and delivery of health services, and that MCAH can promote collaboration between agencies. Now I will describe a few tools and projects that we have funded that might help enable improvements in the system of care coordination in your counties. When applicable, there are references for where to find the resources in the bottom left-hand corner of the slide, and we will also follow up with a reference sheet after this webinar. This first item is a validated tool, the Pediatric Integrated Care Survey, or PICS, which measures a family's experience with the integration of healthcare and related services for their children. The PICS asks the family to identify all members of their care team, county programs, and their agency partners serving children and youth with special healthcare needs and their families could use this tool to assess how well care is being coordinated in their county. This next tool, Achieving a Shared Plan of Care, is one of the most often downloaded publications on our website. It is a very user-friendly tool designed to develop a shared plan of care. MCAH directors could promote the use of this tool with families of children with special health care needs that are part of their programs. The next 3 slides highlight recent projects that have recommendations that may be useful as you embark on the needs assessment. I'm going to go through these fairly quickly, but I urge you to look back at the lessons. This first slide speaks to the need to tier services based on needs. Important to note here is the need to share data across healthcare entities, and that information about social determinants of health, an area which is very important to MCAH directors, should be included in tiering for services. This next project looked at lessons from Medicare that could be used within coordinating care for children with special health care needs. As I said earlier, much of the research on care coordination services has been in the aging population. Especially important for MCAH directors from this work is the need to identify and target specific subgroups and to facilitate information sharing when possible. This next project, a National Care Coordination System Standards project, has just begun with the National Academy for State Health Policy and involves developing system standards. These will provide guidance on the key components for care coordination systems at the state, local, and health plan levels. And so I urge you to look back over time to our website to learn more about this project. Now, back in 2017, I spoke to your group about the California Community Care Coordination Collaborative, which is an initiative to bring together all the stakeholders within a county that serve children with special health care needs. The counties that participated are highlighted here. In many counties, the MCAH directors were key partners. In counties where there is not yet a 5Cs type group, MCAH directors could consider convening these key partners to begin working on improving interagency coordination. Now, I'll briefly touch on 3 important care coordination challenges in California. One area that is ripe for improvement in care coordination is within the school system. A 2014 report highlighted many challenges for children with special health care needs when at school, which are listed here. As of 2014, California did not use any of its Title V funds to support school health services. So this is an area that county MCAH directors and the state could focus their efforts. Noteworthy here is also that county public health agencies could contract to assist with the health care that is required during school hours for children with special health care needs. Another care coordination challenge is accessing durable medical equipment and medical supplies. You can see statements from parents highlighting this challenge from a recent Foundation report. "22% of families in 2017 that were surveyed reported waiting a year or more for needed equipment and supplies, while an additional 16% mentioned having cases that were still unresolved. Almost 20% of parents said that they had experienced delays that meant their child had to stay in the hospital until they received the equipment that they needed. A third challenge is access to mental health services. In 2017, the National Health Law Project surveyed legal, child, and policy advocates and family representatives who work to provide access to services for children with special health care needs in California about which services they felt were the most difficult to obtain for children. Mental health care and counseling was number one, though the answers were quite varied, as illustrated here. Respondents were then asked to select the biggest barrier to accessing mental health care. It was lack of a responsible person or program to access the services. Contributing factors included long waits, shortage of providers, difficulty navigating bureaucracy, delays in coverage, and no one entity in charge again. MCAH directors could work with their mental health colleagues to improve this situation. I hope this information is helpful as you embark on the needs assessment, and I am now happy to take questions.
Holly, that was very, very informative. Do you have any specific questions for Holly? You could either chat your questions in or raise your hand and we can unmute you. And have we received any questions?
We have a percentage of children with special health care needs need care coordination given the broad definition of children with special health care need.
Good question. I think that speaks to the importance of assessment in the care coordination and care planning process. You really need to look at what the needs of the individual family are so that you can assess the level of care coordination that they need. I would be comfortable throwing a guess out there, but perhaps, Ed, do you have additional comments you want to make?
No.
Other
We do chatted question. Oh, where'd they go? Strategies for addressing HIPAA concerns when creating and using your plan of care.
Well, this question comes up a lot, particularly with the 5Cs project and with the in the Giving a Shared Plan of Care doc. I think that the concerns are much lower than people actually believe them to be. You can develop a simple consent form and have it reviewed by a county legal expert, and as long as a family consents shared, information shared between providers, it's really not a major concern.
Up on that, Holly, is there from your research on that and your work with the Shared Plan of Care, who is the entity that seems to be creating that, given the amount of time that it takes? Is it the child specialty care provider, the child's pediatrician, or a family the one that's spearheading this?
Care system, I think it would likely be the physician that has the most interaction with a family. So sometimes a child has very complex medical needs. Actually, one of their specialists may sort of to the family serve as their primary care provider. So I think it does depend on the role of different physicians in a family's care.
Let me jump in on that also. We have a project going on at Johns Hopkins now to develop a computerized data collection process that would actually populate a plan of care so that then the time that would be spent collecting that information can be done beforehand, and the healthcare team can sit down and work on it together much more efficiently. Often also in practices, and this is a role that in the CCS program ought to be the case manager's responsibility, at least to kick this off.
And the project at Johns Hopkins, Ed, is that going to be in the electronic health record?
The hope is that it'll be linked to the electronic medical record. It's still in development stage, but that's what it ought to be ultimately, yes. And ideally should be able to glean data from the health record to put to that. But most of the shared care plan has to do with identifying the family's goals and then identifying what services are going to be necessary, and then deciding who's going to be responsible for making sure those services happen.
Questions?
We have a large number of questions at this point, and I know that Allison still needs to speak. Did you want just one more question, or how many? And I'll save all of the questions as well for the individual presenters.
I have one that's related to care coordination. Maybe we do that and then on that topic right now, or are they related to care coordination?
They are, but there is one that it directly relates, and that is a question: are there details or resources within your model that speak to reimbursement of care coordination?
Yeah, I think we have some work on our website that could speak to some possibilities for reimbursement for care coordination. One document is the Care Coordination Conundrum, which talks about the challenge with care coordination, which is that everyone agrees that it's important, everyone agrees that it should happen, and figuring out how much a patient should get and who should pay for it is the challenging part.
Another website from Got Transition that looks specifically at paying for transition services, but they've identified various ways of going about paying for it that could apply to care coordination in general. Part of the reason we're doing our project on developing standards of care for care coordination is that although everybody agrees it's important and ought to be paid for, what constitutes care coordination currently is so diverse that payers are reluctant to get into paying for something when they don't know whether it's needed and whether it meets any kind of quality standard. So once the national standards are developed for care coordination, then health plans will be better able to assess what it is they're paying for and are then going to be more likely to pay for it. So we're currently in a catch-22. People won't pay for it because they don't know what it is, and people don't know what it is, so they're unwilling to pay for it.
Well, let's move on now to Allison, and then we will come back to other questions after Allison's presentation.
Thank you, Jennifer, and thank you, Holly, for your presentation on care coordination. I am now going to focus on family engagement, and we'll be looking at the parent perspective of the healthcare system, that parents have for improving the system, why the parent voice is essential to effective systems improvement, and some of the projects that the foundation is funding in this area. Slide, please. The purpose of this study, in their own words, which is available on our website, is to gather information from families whose children require a wide range of medical and non-medical services, typically involving multiple providers and multiple systems. These families were asked about the effects of caring for a child with special health care needs on the family, also about their experiences obtaining needed services for their children, and recommendations for improving the system of care. The study was primarily based on the belief that parents represent only one interest, the health and well-being of their child, and that family, as daily users of this system and services, understand best what works well and what doesn't work well for their family and for their child. The main themes that were identified will probably be familiar to you based on past needs assessments and other literature in the field. Next slide, please. So this diagram represents 4 common themes identified in this study. First of all, in the circle working outward, is that this system is not designed for families. Many families feel that the system is really designed to accommodate providers, staff, and healthcare professionals rather than families. Many families also feel that they're not being heard by professionals. Moving outward, we have system complexity and fragmentation in terms of the medical system as a whole, medical care, and the other services that families use. Holly already painted a picture of the need for assistance with coordinating care and navigating the system. Another important point is that families have the view consistently that the most reliable and experienced, the reliable source for guidance and support is other families. The theme is a family burden. Parents, they kits for their children, they're case managers, they're care coordinators, they're managing medical services, support services, funds, education, and other social supports. Generally, feelings associated with the care is they are fear, vulnerability, and isolation. Some feel that they are in a constant state of crisis. And then, of course, there are the additional financial burdens that families face. So all of these burdens are huge, and they go largely unrecognized. There are race, language, and income barriers. The previous 3 issues are compounded by additional challenges for families of color, those who do not speak English, and those who have limited education or are low income. This may be due to lack of access to information that's understandable, usable. Sometimes income affects the type of health care that families receive, the type of health insurance. Sometimes that can have access as well. Race and racism, of course, are also powerful when we look at service delivery. Next slide, please. So those are primary care providers outside of the formal healthcare system. This national data show that 5.6 million children with special health care needs in the U.S. receive 1.5 billion hours of unpaid family-provided health care annually. And you can see that this results in $17.6 billion in missed earnings annually. In the state of California, you can estimate about 10% of these national findings to reflect the numbers in our state. Next slide, please. This additional 2009-2010 data from the National Survey of Children with Special Health Care Needs is broken down for California and illustrates some of these burdens in more detail. A third of parents report cutting back or stopping work to care for their child. A quarter report family financial problems as a result of their child's condition, and many spend full work days coordinating care, not including providing medical treatments, attending appointments, normal child rearing, and other household duties. Next, please. So going back to the In Your Own Words study, in addition to telling their stories, families offered recommendations for improving the system. So California, if you want to address some of these family burdens, these are 9 different things you can do to help make the system work better for families. And I'm not going to read through them all, but reforming programs to simplify eligibility and enrollment, all the way to better educating healthcare providers to promote empathy, cultural sensitivity, communication skills, as knowledge of how to identify and use community-based resources. Next, please. A note made in the study is that fundamentally parents feel that they don't have a voice. So what they do is listen to parents. In the study, parents placed very strong emphasis on meaningful family engagement and decision-making around policy, system design, and service delivery quality improvement. Next, please. Okay, so how is California doing in terms of engaging families? In 2014 and 15, we funded the Association of Maternal Health Programs to conduct a national survey of family engagement in state Title V, MCH, and children with special health care needs programs. The report is available on our website. Today, I'm going to look at a separate county-level survey of CCS programs in all 58 California counties that was conducted in 2016 to 2018. Some may already be familiar with this. 76% of these respondents were county CCS administrators, and we will look at some of the key data from the survey. Though before moving to the next slide, I do want to point out that at the national level, children with special health care needs programs had higher levels of family engagement than the MCH programs. So next slide, please. So in this, we have of the high-level survey results. This is by county. So in the first graphic, we see that 39 counties reported that they either encouraged or sought family input. And that input ranged from having a comment box for parents to conducting surveys, having families participate on groups, and having family advisory committees. And you can also see that about 45% rated themselves as fair in terms of the effectiveness of these family engagement activities. Slide, please. In this slide, we see the results from 3 separate questions that asked if the county program had a family-centered care work group, if there was a parent health liaison, or family advisory committee. And here it is important to note that prior to the Great Recession and budget cuts to counties, more counties had funding dedicated to family engagement activities, for example, parent health liaisons. And while some counties managed to retain parent health liaisons and continue to have active family advisory councils, others have said they would like to have more family engagement activities and referred to budget issues as a barrier to being able to implement these activities. In addition to budget, other common barriers indicated on the survey and are in line with those from the literature on family engagement include family time constraints, the lack of staff time for families, training and mentoring families to be able to serve effectively, unable to reimburse family, and again, budget limitations. So whatever these reasons or barriers may be, is an opportunity to learn from the programs that have engaged families a priority and have been able to maintain their family engagement activities despite these kind of barriers. This is something for everyone to consider when working on Title V block grant objectives to increase the number of family advisory councils, parent health liaisons, and family-centered care committee work groups in the case. And please. You will note on this graph that the differences reported in benefits from California versus the nation as a whole. This would indicate a need for increased family engagement in our state and or possibly improvement in how families are being engaged. Slide, please. So these are just an overview of the survey. Overall, it has given us information that while some efforts are being made to engage families in California CCS programs, a lot of work needs to be done to achieve meaningful and effective family engagement. The good news is that 41 county CCS programs indicated an interest in receiving training on how to increase family engagement. And we'll now look at some of the state and national efforts around improving family engagement that you'll be able to be involved with or learn from during the needs assessment process and on an ongoing basis. Next slide, please. So I'll shift now to some of the Foundation's efforts within our family engagement program area. His lived experiences make them uniquely qualified to partner in shaping systems-level policies that can improve systems of care for all children. And our long-term vision is to see meaningful family engagement integrated into all public and private programs or agencies serving children. Next, please. As I'm sure you're aware, there are a variety of definitions about or of family engagement, and most of them do have parent-professional partnerships at all levels of the healthcare system as one commonality. This slide is what we at the Foundation are using to guide our efforts. But what does meaningful family engagement mean? I hear that question pretty often. And essentially, if that families are valued for their unique perspective, they're provided with proper training and support and orientation, and they're compensated for time and travel. Warrant Leadership graduate in California, I think, said it best. She said that families want to give input. They want to help improve the system or improve services. They just don't want to be the only person at the table who's paying out of pocket to be there. This compensation issue is a major barrier, and we're going to look at some others. Next slide, please. They're probably familiar to you. These are also listed in a family engagement fact sheet that is available on our website as well. We hear all the time that parents are not prepared, parents don't have time, not in our budget, or we don't know how to engage parents, or we don't have policies and protocols in place to do so. And we are already engaging families, and we know that in some counties there is actively engagement and robust family engagement programs. Wonderful, and if you found a way to overcome these barriers, we need to hear about it, and please share with others what you are doing and how you're doing it. If you're not, we will now look at how we are addressing some of these barriers through our grant making and how may be able to address these barriers as well. Next slide, please. I think many of you are probably already familiar with Family Voices of California, our state's Family-to-Family Health Information Center, and Project Leadership, which we have been funding since 2013. As Jennifer mentioned at the beginning of the webinar, this is a parent training program designed to educate, inform, and support families to help achieve family representation at all levels of community and government where decision-making occurs. These parents are using their skills and experience to tell their stories in an effective way. This aspect of the program is a component. The independent evaluation and graduate surveys in years following have consistently shown that confidence, empowerment, and parent preparedness to advocate on behalf of their children and all other children for systems change. Next slide, please. project started in San Francisco and San Diego and has been expanding slowly around the state. The current grant with Family Voices emphasizes expansion into the Central Valley and Northern California, both underrepresented or rural areas of the state. There are 3 additional states that have plans to, who have already implemented or have plans to implement, and that's Hawaii, Oregon, and Montana. The current phase of funding also includes a partnership with California Department of Public Health, MCAH Division, the National Family Voices National Center for Professional Partnerships Program, California Alliance for Health, as well as the California Department of Managed Care on developing supplementary content to help educate MCAH characters on best practices in family engagement and how to connect with local parents. Next, please. Families are deeply affected by systems-level issues that many are motivated to become active and involved advocates for change. 4 of the main goals for graduates include serving on groups. Some of these are the Medi-Cal Children's Health Advisory Panel, CCS Advisory Group, and CCS Family-Centered Care Committees, State Council on Developmental Disabilities, regional groups, hospital advisory groups, and that's just to name a few. Contacting legislators, providing testimony, and interacting with media are also primary goals for graduates. Percentages represented here are from a 2017 survey of graduate activities, and knowing that level of involvement has been very high. Next slide, please. We often hear from agencies that we can't find families, so if you have not already made these connections with Family Voices of California or your local Family Resource Center, please so. You can find contact information here on these websites. Connect with families. You can find out whether or not there's a project leadership training in your area or how to have one hosted in your area. Family Resource Centers are also a great resource for family support services trainings and informations if you are already not familiar with them. Next slide, please. Another grantee, Lucille Packard Children's Hospital, which is a national leader in family-centered care and a model for how family engagement has become integrated into the organizational culture. Earlier I mentioned how parents feel that the most valuable resources and support comes from other veteran parents, often referred to as parent mentors, parent navigators, or parent partners. In the past, we have funded Lucille Packard Children's Hospital and a family-centered care network, a first phase of a parent mental learning collaborative, and are currently funding an additional phase for the learning collaborative. And the goal is to establish our mentors as paid members of the healthcare team at hospitals throughout the state, but not exclusive, nationally as well. And other collaborative members include the Health Plan of San Mateo and San Mateo County CCS. So it is something that can be done in hospitals, out of hospitals, excuse me. And this project has shown that in of family engagement accepted at a leadership and organizational level, that this type of organizational change is possible. Next, please. The last thing I'll talk about is a project we're funding with Family Voices National. They are currently, they already have developed a framework for assessing family engagement and are currently developing and piloting a systems assessment tool and a toolkit. These resources are designed to help care organizations, systems, state agencies, insurers, researchers, and other programs or initiatives that serve children and youth and families. That's used to assess efforts in family engagement at the systems level, or it may be used to guide the design and processes for improving efforts, or could also be used to plan new efforts if an agency or organization is looking to create policies and protocols for family engagement. Next slide, please. The are broken down into these 4 domains: representation, transparency, impact, and commitment. I'm not going to go into detail about them. Each domain includes a set of criteria, and you can find an archive to a recent webinar on our website that does go into much more detail about the framework and the tool, and we also have an issue brief on our website called A Framework for Assessing Family Engagement and Systems Change. So if you're struggling with how to engage families, this tool, whose anticipated release date is this summer, may be an effective way to guide your efforts. And if you're already engaging families in systems level initiatives, you will be able to assess these efforts and determine areas for improvement. Please. Finally, I will be moderating a session at the ANTIP Annual Conference in San Antonio next week on assessing family engagement, and this tool developed by Family Voices. So if you're there, please stop in. The session includes representation from Maternal and Child Health Bureau, of Maternal and Child Health Plans, and of course, Family Voices National. And I'm happy to take any questions.
Thank you so much, Allison. I know we don't have much time left, but Adrienne, do we have any questions that have been chatted in or questions we didn't get to from Holly?
We do have questions from Holly's session still, and I also have 2 questions from Allison's session. Actually, now being asked a couple more, but where would you like me to start?
Start with the ones for Allison and then see if we can, finish those and then go to the ones from Holly.
Okay. So the first question is, for the counties that did not want more training on family engagement, what were some of their stated reasons?
Good question. I'm not sure if they stated their reasons for not going to additional training. I don't believe that they did provide additional information. It was a yes or a no, or I know.
And the second question is, in these family engagement meetings, is the topic of trauma-informed care or adverse childhood experiences discussed?
And that would depend on the view for the family engagement topic. I'm not sure what exactly the question refers to, but I do know that in trauma-informed care and ACEs, there is also emphasis in including families.
Waiting to follow-up question. Anyone? Okay. Did you want me to ask one of the questions that came in during Holly's presentation?
Yes, please do. And then please also put up the poll. Folks, you could take a couple of minutes to answer this quick poll. That helps us with feedback on the webinar. And yes, please go ahead and it's one of the other questions that came in for Holly.
Okay.
All right, I see one for Holly. So while you're you've already got the poll up. Okay, great. Go ahead.
You see one, you can go ahead and ask it because I've got to scroll back anyhow.
Okay, well, one question that came up, many of the care coordination concerns have been in place for many years, only getting worse as time goes by with specialization. What time do you foresee as implementing these solution suggestions, or is it up to the parents to implement this now? Thank you.
Parents are doing the best they can with the system that they are presented with. So I think it's up to us as healthcare system providers and researchers to do what we can to take their suggestions, which Allison presented and are actually very similar to the ones that Ed and I presented, and really try to start addressing some of them. You know, one of the first steps might be the shared care plan. that providers, health plans, or systems, or county programs could work with families to develop care plans so that they understand what families' needs and goals are, and then begin to build services around those needs and goals. And I want to open this up also to Allison or Ed if they have additional insight they want to share.
This is Ed. Work is already going on. Medicare currently pays for chronic care management services. So Medicare is now paying, and that's a national program for care coordination. Unfortunately, aren't involved in that. There are a number of sites around the country that are pilot testing different ways of providing and paying for care coordination. And so I would encourage some of the people on the call today to think about whether their county or their program or their managed care company might be ready to pilot different ways of approaching this. I think it's going to be several years at least before the state of California takes this on in a comprehensive fashion. But what is to lead to those statewide activities is some positive experience in the counties, and so I'm encouraging everyone to consider whether they ought to do it, figure out who they want to serve, what services they want to provide, and what payment mechanisms they might want to try out.
All right, maybe we have time for just one more question. Adrian, do we have another question?
We have a couple. Was who most commonly does the care coordination for children and youth with special health care needs?
Parents. Let's see. No, does somebody have a different answer?
Again, this is Ed. The answer is it depends. If you're a CCS enrollee, then every CCS enrollee is supposed to have a case manager, and they should be doing some aspects of the care coordination. If you're a private agency, a nonprofit agency, you should be coordinating your services with others. In most doctors' offices, doctors claim that they're doing care coordination. Generally, they're not. But there's a strong recommendation nationally that clinical practices each have at least one designated person who's the care coordinator. So it depends on the circumstances, the payment structure, and the population that's being served.
Any last shorter, maybe pressing questions, Adrian?
So we do, and the person that asked this will have to forgive me. I think that I understand what you're asking, but they're asking about what happens depending on the county or area that the child lives in if the parents do the needs assessment. So I'm assuming that they maybe live in different places. But I think that it's getting at the complexity of what happens across counties in terms of care coordination for children with health care needs.
Does anybody answer to that question?
I'm sure I understand the question.
Yeah, so, and that's the last question that we have in there. And you can unmute the person that asked it if they're here. They're not. I don't think that they're still connected. They responded.
Let me just jump in then and say that needs assessment is a joint activity between the healthcare team, others, school nurses, teachers, and so on, and the family. So it's not either or, it's all needs to be involved in deciding what the needs are, and the family has to have first say at that, and then the family has to be able to be the ones who prioritize which needs should be addressed first.
Well, thank you, Ed. We are at time. So that was a terrific presentation. Thank you to all our presenters, Ed Shore, Holly Henry, and Allison Gray. Everybody saw their contact info in the slides, so you can follow up with them if you do have specific questions. And encourage you to take the poll if you haven't done so. And oh, there they all are. And thank you all for attending our webinar today. We have recorded it. It will be available on FHOP's website probably within a week. So if you have colleagues that didn't get a chance to listen in a webinar today, or if you want to go back and listen to a particular segment of the webinar, it will be up on our website in about a week or so. And have a terrific day.